Good morning. I think we'll get going. For those of you I haven't had a chance to meet, my name is Ward Fleming. I'm a member of the Department of Medicine and the Faculty of Medicine here, and helped to run the course with Nishan and Margot on patient safety and quality improvement, along with the Health Quality Council of Alberta and the Office of CME. And it's my pleasure to welcome you this morning. This is the 5th year that we've run the course, and the 5th year that we've had a day in March where we can celebrate all the presentations that are going to be made later today of the participants that participated in the course through the last 6 months. As has been our tradition, we've always invited an internationally acclaimed speaker to come and start the day off, and we've had some great speakers in the past, and this year's no different. Before I get to introducing our visiting speaker this morning, I'd just like to acknowledge and thank the people that were able to put this course on over the years, and particularly Margot and Nishan, who do the backbreaking work of making sure that the course runs every week, that the projects are coordinated, and that this day actually happens, along with Anna and Deborah, who also provide a huge amount of support. So to you folks, thank you very much. The course has been a huge success over the years, and it's garnered attention, and most recently the Royal College of Physicians and Surgeons has been looking at both the University of Toronto and the University of Calgary as the models that have put on certificate courses, and we've currently got an application in front of the college to mold that course into something that the Royal College can now offer as a diploma program, and we don't know whether that's going to be successful, but we suspect it probably will, so stay tuned. We've had, as I mentioned, many distinguished speakers over the years. Last year we had Eduardo Salas, internationally acclaimed teamwork researcher, who's written over the years. Our very first year we had Jim Reason from the UK, who admittedly probably is the grandfather of safety in industry, and we recruited him into healthcare over the last 10 years of his career. And this year we kind of reached back over the pond again to ask a internationally known speaker to come to Calgary, although we recruited him to Canada about, was it 13 years ago, Mark?
Yeah.
13 years ago. So we've asked Mark Fleming to come from Halifax to be our keynote speaker this morning. Mark is the CN Professor of Safety Culture at St. Mary's University in Halifax, and has held that role for many years, and is an expert in safety culture. And if anybody in the course remembers, back in September, I would have talked to you a little bit about the National Quality Forum that convened a group of experts back in 2001, 2002, produced a report on the 30 practices that they would recommend healthcare organizations invest in order to make care safer for patients. And at the top of that list was create a healthcare culture of safety. The problem with that report is they didn't tell us how to do it, but they knew it was important. And so Mark is here to talk a little bit about his research and also to reflect on patient safety culture. Mark's interest has been in how do you measure culture and help organizations understand their culture, because the old adage, if you can't measure something, you probably can't improve it. And culture, as we all know, is a little bit nebulous. We know it's critically important. It's hard to define, hard to get there, but there's certainly tools and techniques, and Mark has worked in industry to develop those. And so much like Jim Reason, where we took somebody who had a lot of industrial experience, and that's where Mark's training has been in, both in his PhD and in his bachelor and master's degrees, and he has those degrees in both in human factors and psychology applied to industry, but we've dragged him into healthcare, much like we dragged Rona Flynn in and Eduardo Salas and Jim Reason, because we recognize the importance of learning from experts outside of healthcare and hopefully adopting what they've learned. And so Mark's going to reflect this morning on, so where is the patient in patient safety culture? And we've done a lot of work over the years in trying to understand how do you measure patient safety culture? Can you measure it? And I think there might be a bit of a missing piece in all of that. And Mark's going to address that this morning. So, Mark, welcome to Calgary, and thanks very much for coming.
Thanks, Ward. So I'm just going to start this so I know what I'm doing. Okay, so thanks everybody for coming, and thanks to Ward and Nishan for inviting me here to spend some time talking to you. It's great to be among esteemed colleagues like Ed Salas and James Reason. And James Reason, for most of us who work in this field, is the sort of person who we try to be like to a greater or lesser extent, to try and make the work that we do applicable and understandable to industry and to healthcare. And Rona, who was my PhD advisor when we were in Aberdeen, again working in oil and gas, but also doing some work in healthcare to a greater or lesser extent. So I'm going to sort of spend some time, got some sort of thoughts that I want to share with you. So I've got sort of three sort of broad objectives. One is to spend a bit of time talking to you about the nature of culture, what that is, what that looks like, and to maybe to get you to think about it a little bit and to try and think about how culture influences what we do. I'm going to talk a little bit about how we go about assessing it currently in Canada, and some of the strengths and limitations of that. So partially how we got where we got to, maybe why we should be somewhere else, and how you might be able to get there. So some limitations about what we're currently doing, particularly about sort of thinking about patient engagement, patient involvement around culture. And then I'm going to talk a little bit about some work that research that we're currently doing around patient perceptions, around patient safety. And then I'm going to sort of finish up with a little bit of a talk about some ways that you can maybe think about improving safety culture within your organizations. We'll sort of have a bit of a chat about that. So sort of what is culture, how have we gone about measuring it, strengths and weaknesses of that, and then some improvement strategies. That's the basic sort of plan of the morning. What Ward didn't mention was I'm originally from Ireland, and growing up in small town Ireland in the 70s and 80s, there wasn't a whole pile to do. So you could either be at home and your parents would be giving you a hard time, or you could go out, but there was nowhere to go out to. So I spent a lot of my teenage years walking around in the rain. And I blame that on the fact that now I can't think unless I'm walking. So you'll find I'll walk around a bit, because if I stop, then my brain stops working and I can't remember what I'm going to say. So hopefully the pacing won't drive you too crazy. Unfortunately, I can't do a whole pile about it. The other thing is that being from Ireland, I speak a bit quickly. I'm working hard to not do that at the moment. And as time goes on, and as time gets shorter, I tend to speak quicker and quicker. And at some point in time, it'll stop making sense. So if it stopped making sense, then someone should wave their hand and say, you're not making sense anymore. And then I'll go back and try to slow down. So you need to sort of keep an eye on that as a sort of concept. So I like to use a sort of a range of different quotes. I like this one from Einstein. You can't solve the problems by using the same kind of thinking we use to create them. So I think one of the things that's helpful about culture as a construct around improvement in any organization, but particularly in healthcare, is that it helps us think about the problem from a slightly different perspective. Right? So if our training is in one particular way, when we approach it from a particular strategy or perspective, then having a different way of looking at it can give us different ways of improving the problem. And I think culture is important for a whole range of reasons, but I think one of the real benefits of looking at patient safety from a cultural perspective is it gives you a different way of thinking about the nature of the problem, and in doing so, you can come up with different types of solutions, right? So it is a useful way to sort of think about things differently and look at the problem differently And by doing so, you end up with a different sort of frame of reference in terms of the logic of the nature of that sort of problem. And I think often we as individuals, we'd like to, particularly in sort of Western cultures, think of ourselves as individual and different, right? And you know, that's not untrue, but I think we overestimate the extent to which we're actually individuals. And I think that's a real sort of, the power of culture is that it governs a lot more of what you do than you sort of think you do. And it often does it in such a subtle way that we're not necessarily even aware of it. So to give you sort of an example, all of you here are sitting quietly looking at me, okay? And that's not necessarily a normal thing. So if you think about when kids go into school first, that's not what they do, is it? Right? You know, if you go into sort of a class of 5 or 6-year-olds, you know, they're, you know, underneath the chairs, they're poking each other, you know, they're pulling each other's hair, they're running around. And a lot of what early education is about, maybe all of what education is about, is getting people to sit still and pay attention. And they'll do it even when they're bored out of their mind, right? You know, you could find it, you know, that sort of dead-eyed stare that people develop. I mean, students, particularly undergraduate students, develop it particularly well, right? You know they're nowhere near listening to you, but they give all the semblances of that they're really, you know? And to a certain extent, that is how culture is operated, right? From a very young age, we bring people into a setting, right? And we teach them that what they're supposed to do is sit still and pay attention. And as they get older in school, they learn that if you're bored and you're not paying attention, you have to pretend you're paying attention, right? And that process has resulted in you happily sitting here without being told that you had to sit down, had to look at me. There's no procedure that was written to tell you this is what you're supposed to do. Does that sort of make sense? And what's interesting is that if you do something different, people will start looking at you and, you know, staring at you and, you know, what's that person doing, right? You know, and that sort of sense is how we control each other and how the culture determines what we do, right? And it's actually quite difficult to do things that aren't in that sort of context, right? We have a real tendency to want to conform to those sorts of norms that we've learned over years and generations. And as a society, we control each other's behavior to a greater or lesser extent. Does that sort of make sense? So Ward mentioned I came over to Canada in 2001. And we used to live, we lived in Edinburgh, but before that we lived in Glasgow for a period of time. And we had an apartment. And when we went from our apartment to the local store, it was, you know, maybe, I don't know, 50 yards, something like that, really, really close. But you could not walk that distance without stepping in dog dirt, right? It was sort of some sort of minefield. You had to navigate your way from the apartment to the store. And, you know, it always, you know, was annoying and you know, sort of bother you. And then I remember arriving in Canada, it was in the fall, and being up early and going for a walk around the local neighborhood and seeing, you know, and one of the things you notice in Canada is that everybody's got a dog, right? You know, there's probably more dogs than people. And it is, you know, and yet, so you watch these people and you watch them go around and thinking, this is going to be a nightmare. But yet you don't notice, at least in Halifax, any dog dirt, right? You can see people, but with lots of dogs, but you don't have it all over the place. Yet in Glasgow, not so many dogs, but the dogs that were there were making a mess of the pavement. So what's the difference between Halifax and Glasgow? Yeah, so they both have the same laws. So there's a fine in Glasgow for doing it, for not cleaning up after your dog, as there is in Halifax. And you know, you watch people in Canada. And you sort of now, having lived here a bit longer, you sort of know what to do, how to make people to sort of comply with the norm of picking up the dog there. So we, in our neighborhood, we've a young girl who's got a dog, and she's responsible, obviously, for going out walking it. And occasionally, she's not so motivated to pick up after her dog, right? And if it happens to be near my house, you know, I know all I have to do is just make eye contact with her. And it's like, which is great, right? You don't have to say anything, but she knows, and, you know, she knows what I know, right? And therefore she does it, right? In Glasgow, it wouldn't quite work that way, right? It's a different sort of culture, and, you know, we can blame it on Margaret Thatcher, but the sort of concept of society doesn't exist in the same way. So your ability to go up and say to someone, you know, you should pick up after your dog could get you headbutted, right? So it's not going to work so well in that sort of context. So, you know, one of the things that we can see is that our cultural beliefs and how we interact with each other really influences our behavior on a day-to-day basis. Ward mentioned that for years, for at least the last sort of 15 or so years, we've really been talking about the importance of culture in healthcare. So when patient safety started to come to the fore, there was a recognition that if we were going to change things, if things were going to improve, we were going to have to tackle this cultural issue. And there have been a number of different sort of, the IOM report in '99 said healthcare organizations must develop a culture of safety so that organizations, care processes, and workforce are focused on improving the reliability and safety of care for patients. So there was a sort of sense in which we needed to sort of think about how that culture was going to support our activities. And again, the biggest challenge was changing from a culture where one is blaming individuals to treating them as opportunities to learn. So a lot of the early work, and I'm going to come back to this in a while, was really about how can we change how we view the nature of error, and how can we change the way we go about improvement. And it was sort of clear to anybody within that sort of context that to change things, we had to change people's attitudes, beliefs, and norms around what is patient safety, right? And, you know, that has been, I think, an interesting and long journey in terms of getting people to buy into that sort of concept. And this model, relatively simple model of how I think these things operate. So we've got patient safety culture here, just to put that as one sort of box. And I think as I've sort of talked about, giving other examples, that influences patient safety in terms of the norms and behaviors that are accepted within that sort of context. What are the acceptable practices? And if you think within healthcare, and we think of, say, hand hygiene as one of the sort of, you know, typical behaviors that at least infection control people get really upset about, okay? Now, what's interesting is there are many places within healthcare where actually hand hygiene is very good. And actually the rules and norms are actually quite strictly enforced. So for example, in the operating theatre, if somebody breaks a sterile environment or comes in a way that's not acceptable, people will shout at that person very quickly, right? If you sit in operating theatres and observe it, it's quite fun to watch that sort of interaction, because people are very clear about the rules and very clear about what's acceptable in that sort of setting. Does that sort of make sense? And people broadly accept the absolute criticality of hygiene in that environment. But if you move to a more ambulatory setting outside that, then it becomes a lot less compliant, where people's hand hygiene drops, in some cases like a stone, where, you know, people aren't willing to wash their hands to save themselves. And yet, you know, we're both in healthcare, so we can say we've got something different, but the norms are quite different in those sort of contexts about what's acceptable. In fact, sometimes it could be the same individuals who are going to be meticulous in one context, but not so meticulous in another context, right? So the context in terms of what are the norms of accepted practice in that environment really do impact the patient safety outcomes, right? So how we behave, what are our accepted practices, influences the outcomes for patients. And that's normally what we think about. So if the normal behavior is about shaming and blaming people for making errors, then clearly they're not going to report errors, right? If that's the norm, if the norm is to whisper behind someone's back and to say, well, they're not really up to it, you know where they got their degree, right? You know, so there's a whole bunch of back chat that we will use to make sure that people don't report and don't do things. So these norms and behaviors are quite powerful. People like to think that they can withstand them, but actually they're very important. And that impacts patient safety. You can see that pretty directly. It's a direct link. What's more interesting is that patient safety culture can act as an enabler or as a barrier to any patient safety intervention that you're planning or putting in place. So in the context here, let's think about the safe surgical checklist. So people familiar with that, obviously? What's it like implementing that in organizations? Do people love it? Does it work brilliantly? So here we have an evidence-based intervention, right? That was done all the right way, right? So they come up with a plan, they tested in a whole range of hospitals, they showed the benefit from patient outcomes for using this checklist. Everyone thought it was a brilliant idea, right? Everyone loved it to begin with. The guy who wrote the book was on TV shows all the time. He was a mega star. I don't know where he's gone now. But the reality of it for most healthcare organizations is that it has not been particularly effective. People say that's true. That broadly speaking, if it's being used incorrectly, right? And what we can see here is that that was a good patient safety intervention. And I'm confident that if it was being used properly, and where it's being used properly, it's giving direct benefit to some patient safety outcomes, right? Because we've good evidence to suggest that. So when they tested it out and they trialed it to show the benefit, what would we say the culture would have been like among the teams that started using the checklist? Well, would you think there really would have been resistance if you were the one who volunteered to participate in the research project to test the effectiveness? Your culture would have been, we think this is a good idea. We think checklists taken from aviation will work. So we're going to buy into this as an idea, and we're all going to use it because we have a culture where we're thinking about improvement. And this is a common challenge in healthcare, is that often when we have a new intervention, we go and we look for somebody to volunteer to use it. Who volunteers? The people who don't actually need it so much, right? The keeners, the ones who are motivated, the ones who really think improvement is a good idea. So we go to this group, we get them to use this new intervention, it works swimmingly, everyone thinks it's a great idea, we put a poster up somewhere, and then we're going to roll it out across the healthcare organization because we have evidence that this works. And what happens? Yeah, everybody thinks it's a dumb idea, right? And they're not going to do it because it doesn't work for here, and we don't like the color of the paper, and we don't have the time, a whole range of other excuses. And really what I'm saying to you here is that culture, in some contexts, is a real enabler, where the local or unit culture is really positive about the idea of improvement, is trying to think about ways to improve. They are really buying into this concept, and they make it work in your organization, and then that has the benefit that was intended to begin with. So we have this loop that we go around in terms of the culture. When it's a barrier, so when we had the barrier when we tried to roll out patient safety safe surgical checklists, what we found was that there were initially in hospitals, there was early adopters. So this research came out, some surgical teams, some departments decided they were going to use it, they found that it was helpful, and they started using it, and it got adopted sporadically in hospitals. At least in Nova Scotia, what happened was the Department of Health realized that this is a new thing, and they decided that every surgical unit, every surgery should have a safe surgical checklist. So they made that an edict to the healthcare authorities to say, we should do this, right? And my sense is, and I don't have any data to back this up, is that they didn't really, they made it a rule, and then everybody got checklists, but I have no idea whether they're completed, who completes them, or how that works out. Does that make sense? So it didn't work as an intervention. So when it's a barrier, the intervention doesn't work. The real kicker in this slide, and the real challenge around patient safety culture, is you'll notice that there are only two arrows that go into changing your patient safety culture. One comes from your patient safety outcomes. So if you believe and if you're getting information saying that you've got good patient safety standards, then that's going to build your culture. So people are going to be more positive about it in terms of how they feel about that organization. If you're getting negative results and if you're getting a poor outcomes, then you're going to start to believe you've got a poor culture, and it can get into a negative vicious circle. And there's limits to what we can do in that sort of loop. The other loop is through interventions. So if we have an intervention that we try to put in place and it fails, then that has a negative loop back to the culture, right? Where it starts to reinforce those negative patterns of behavior, where not doing interventions becomes the accepted norm, ignoring the administration, ignoring all the ideas becomes that sort of feedback loop. Getting an intervention to work has a positive feedback loop. So the biggest challenge, I think, to healthcare at times is that they need to appreciate that if you're talking about changing or improving the patient safety culture, it requires you to do things. And actually, it requires you to be successful with your interventions. So just because it's going to be difficult because you've got a poor culture, the only way you're going to change the culture is by making that intervention successful. Now, it may mean you have to change how you do your intervention. It may mean you have to do a whole range of different things to make that work, but making it work is your only option. Giving up and saying, well, the culture in that unit is poor, they won't do our safe surgical checklist, what can I do about it, is not actually a solution. That, I think, is the real danger. My concern at times in healthcare is that culture is used as an excuse to do nothing. We're not going to do this till the culture is right, or we can't do anything about it because the culture isn't right. And what I'm saying to you is, your culture is never going to improve until you do something right. And it's not that it's not difficult in an environment where people are resistant, but the only way you're going to make things better is by making those people buy into it to a greater or lesser extent. Does that sort of make some sense? And that, I think, is one of the biggest challenges when we talk about patient safety improvement. We don't make patient safety culture better by having a few meetings or singing a few songs. You only make it better by getting people to do things differently and making those systems work. So if we go back to the safe surgical checklist, if it was decided by a healthcare organization that they were going to make that checklist work in their hospitals, and they encountered a surgeon or a group of surgical teams who said, "Now, over my dead body," the first thing probably would be to sort of try and understand what the resistance was, right? So there may well be valid reasons. So ophthalmology had some valid concerns about using a checklist that took longer than the surgery, right? So there was a sense in which, some of the strategies of using it didn't make sense. So you need to put a lot more effort into selling it and making sure that it makes sense, providing the resources that it's going to work. But at some point in time, you're going to have to think about, we're going to make this happen to a greater or lesser extent. And in that sort of context, you're going to need to check that it's been done appropriately. And if someone's not doing it appropriately, what are you going to do with that individual? So coming from a non-healthcare background to a much more industrial framework of reference, when I'm doing an improvement project within an industrial group, I often run into a range of naysayers who think this is a psychobabble, which is really for girls and not men, right? That's the general sort of reflection that we get in that context, at least I get anyway. And in that context, we end up having to sort of deal with people who are usually relatively influential and who just don't want to play the part. And some of this I blame, or at least is reflected easily in the sort of the concept of House on the TV show, right? That we have individuals who think that, part of their status is about not complying and about not following the rules because I'm so great that if anybody else did what I did, they'd be fired, right? And I can get away with things because of I'm so special, right? And part of my specialness is, part of my ability to do this. And that's what makes me feel good. I feel really good about not having to follow the rules and to be argumentative and to say everything's rubbish and to be difficult. And we find those people in lots of different sort of contexts. What's useful, I suppose, in my job when I'm working with industrial people is that I will identify those people pretty quickly. They're usually pretty open with me and pretty hostile with me because I'm a psychologist, right? So by spotting that, that's actually quite helpful. So I go to the person who's brought me in, who's usually the most senior person, and I say, look, here's the problem, here's the barrier. You need to go talk to that person or this project's going to fail. And in the context is if they don't get on board, then they'll get fired. And I'm very, very comfortable with that. I'm comfortable with the concept that if they're not going to participate in something that's been identified by the group as an important construct, then we can't have them involved. We have to do something with them. And very few people, I can only think of maybe one or two, have actually left the organizations that I've worked for. But all of them will have had the conversation of this is a career-limiting move. You either get on this program or it's a problem, and I have a problem with that. And it's surprising how friendly they become afterwards, right? There's a realization that, oh, well, we thought this was just some namby-pamby thing, and now it's really important, so now I know I need to buy into that sort of concept. And I think that's one of the things that's more difficult within a healthcare context, is that, you know, and you don't need to fire very many people, but one important person actually has a very interesting impact, or at least having the ability to have that conversation. And that's one of the challenges that we have in terms of how do we move that forward. So one of the challenges is, what are the levers we have in place to be able to influence people's participation and behavior in that context? And I think we don't maybe draw on those levers in the way that we would like to. And it's obviously not the first strategy you're going to apply, but the problem is, if you have an influential individual say that this project or whatever intervention is a waste of time and I'm not participating, then it undermines the entire project, right? So it's not just that one person, it's the message that they send. And it then becomes quite difficult to make other improvement actions worthwhile. So you sort of need to fight your battles early to move that forward. And I think that's been one of the real challenges culturally within healthcare. So here's a sort of definition. I like this from Kaiser in terms of what really patient safety culture is about. And it's really, for me, it's about our values and beliefs around continuously seeking to minimize patient harm that may result from the process of care delivery. So it's, first of all, there's an acceptance that patient harm occurs, which often has been hard to get people to accept, but also it is that we're continuously seeking, right? So our current performance is not enough. We're trying to think of new ways to improve safety culture and the processes. So this is the process that's important is, or the culture that we're looking for, is a culture whereby we are continuously looking at our practices to think of ways to improve the outcomes for our patients. One of the challenges within healthcare is that we use a whole range of terms to describe roughly the same thing or slight variants of the same thing. So we have the broader healthcare culture, which is the general norms and acceptances of practices in healthcare, like autonomy of practice and stuff like that. We have culture of safety, which is a term sort of used to sort of describe a desired culture. We want to have a certain culture where safety, patient safety, is important. We have safety culture, which is a more broader term in the sense it's not saying that it's a positive or negative culture, it's saying it is the relative priority placed on culture within this organization. So this is sort of saying it's a certain type of culture that we're looking for, and this is really talking about just this is safety culture that we have, right? It could be good, it could be bad. And in healthcare, a lot of the interest in culture was really about blame culture, right? That was very dominant in healthcare. That if you admitted to a mistake, if there was a mistake that occurred, there was a tendency to blame the person that admitted that mistake, right? And focus on that sort of problem. To give you an example, I was doing a workshop for a group of residents a number of years ago, mainly talking about reporting and blame in this particular workshop. And after the workshop, one of the residents came up and spoke to me and said, you know, he had an incident when he was an undergraduate medical student. He was doing a rotation when he was doing observation in a surgical unit. Wasn't doing anything, he was just in theatre observing. And when he was observing the finishing of the surgery, he was watching the nurses count that all the swabs and all the things had been taken out of the person who had had the operation's body. And he had a sense in his head that they were counting incorrectly, or that in his mind, what he thought there was something left in the patient. But he didn't say anything because he wasn't sure, and he assumed, it was his first or second day there, that they knew what they were doing and that this wouldn't happen. So blah, blah, blah. Turned out that within sort of 45 minutes, the patient had to be returned to surgery because there was something left in their body and had to be opened up again, had to be removed and taken out. So he was like, oh, I should have said something, right? I should have said something because I knew that, or at least I had a suspicion of it, and I could have saved that person that unnecessary extra trip to the theatre and everything associated with that. So at the end that evening, he sent out an email to all his classmates who were on that surgical rotation to say, this happened to me, where I was observing surgery, this was left in, this happened, and if you were in that same situation, you should raise your hand and report and say there's a problem here and raise a concern. He nearly got thrown out of medical school because the surgeon who he was observing went nuts, saying he was telling tales at a class, he was besmirching his reputation, making him look bad, and he was absolutely traumatized by this experience, considered leaving medicine a number of times, and even now, and this is some years later, if he runs into a colleague from his undergrad medical degree, they say to him, oh yeah, you're the snitch guy. They still see him in that mindset as being the person who told, right? So that culture is still there in terms of, well, what do you learn out of that? Now, what was interesting is, when speaking to him, I said, well, what would you do now if you were back there again? And he said, no, I would still do the same thing. I still was right. I'm just really upset how everybody else is, right? And I thought that was really interesting. So some change, I think, has occurred, but I think this is still a huge issue in terms of the healthcare culture, in terms of how we deal with people who raise concerns and how people respond in that context. And a fair and just culture is what we're looking for, where people don't fear reprisals and are going to be treated fairly. Okay. So one of the things that I like to do is to sort of talk about safety culture in different sort of ways. So we can break safety culture down into strong and weak, where we have a safe culture and an unsafe culture. So in a safe culture, everybody complies with the rules and things are safe. Unsafe culture, people don't do such things. They violate rules. Strong, where it's very consistent, and weak, where it is much more variable. So over here, you can see in the center, these little sort of smiley faces, these are the people. Their behavior is very consistent and very close together, and all of it's in the safe zone. And if someone came into that environment and decided to behave over here in an unsafe way, they would be victimized, they would be bullied, they would be excluded because it's absolutely necessary to follow the rules and procedures, right? There would be very hostile response. Over here, it's a bit more of a laissez-faire sort of attitude. You can act safe or not act safe, it's up to you, everybody's an individual, we do our own thing. It's not really as safe as this because you have some people in this amber zone of less safe, but we have, broadly, because individuals happen to be safe, we have a reasonably safe outcome. Over here, you can see in this unsafe zone, you can see that there's more variability again, but we have people acting in the unsafe part of the area, which again reduces your performance. And then over here, where you have a strong but unsafe culture, where people have accepted that this is the way we do it around here, and we know that it's unsafe, right? But we choose to do it this way. And there's good reasons for it, at least in our mind. And if you chose to go in here and do it the safe way, you would be excluded, vilified, and treated poorly, right? That's how it works in that sort of context. Does that sort of make sense? So the thing that's tricky about culture is that here, it's easy to move people towards this. And even here, where it's weaker, you can try to move it. This to this is very tricky. You're going to have to remove a lot of people to do this, right? Because they really believe that they're right. And anybody who comes in is going to be, traumatized. A new leader comes in, they'll get rid of them. A new process. You're going to have to break this group up to be able to make a cultural change because the beliefs are so strong. Now, obviously, we've broken into the 4 categories, and that's a simplification. Very few cultures are this strong, but it gives you a sense of cultural strength is going to be an important thing to think about. I'm going to talk. So when you're talking about organizational change in terms of cultural assessment, you can look at it in terms of the organizational level, which is doing a survey of the entire entity, and Alberta Health Services, as part of the Accreditation Canada, did a survey of all employees in a couple of, probably 18 months ago now. And you can try and make some significant changes, although it can be challenging. More typically, where there's evidence of improvement, it tends to be at a unit level. So when we get cultural change, it improves because we can do it at a unit level. So it's a more focused intervention, and we get incremental improvement. I'm just going to talk briefly now about the assessment process, and we talk about safety culture as being multidimensional. And when we look at the dimensions that existed in those early studies on patient safety culture, they talked about leadership, resources, priority for safety, effectiveness, organizational learning, frequency of unsafe acts. And this list, and other similar lists like it, really look at the origins of where a lot of the assessment of patient safety culture came from. So as Ward mentioned, people like James Reason and Rona Flynn went from industrial contexts and moved into patient safety culture, right? So we went from safety culture to patient safety culture. Sort of makes sense, you build on previous research. The problem is that we were in a mindset of what's relevant in an industrial context. And it's not that these things aren't relevant, but they're just not the complete list. Leadership and commitment is important, although it's not in the same hierarchical way that would happen in an industrial setting. So the CEO of a healthcare authority is important, but the liver transplant surgeon may be more important, right? So who are the leaders and who are the really influential players differs to a certain extent in healthcare than it does in more standard commercial companies for whatever reasons. Priority for safety over production looks slightly different in healthcare than in other domains. So some of those early attempts and a lot of the psychometric problems we had with those early attempts really limited, I think, our development of those safety culture surveys. So even today, in my mind, I don't think there's any patient safety culture survey tool that stands up to reasonable, rigorous psychometric evaluation. One of the better ones is the one that's used by Accreditation Canada. It's got much more revision and improvement about it, while others are pretty ropey. And I think some of that is that conceptually we maybe didn't understand the construct very well. There was a paper written a couple of years ago now, maybe 4 or 5 years, arguing that actually it's not that our questionnaires are bad, it's just that the concept changes within different locations, which psychometrically makes no sense. If the construct is not generalizable, it's not a construct, right? So we have some real measurement issues in terms of how we approached it. The New York modified Stanford instrument was developed. It had in its first iteration organizational leadership for safety, unit leadership, perceived state of safety, shame and repercussions, learning, and it had reasonable psychometric conditions, and it's used by Accreditation Canada. It's gone through another iteration, I'm going to talk about that just now, where they've changed the dimensions, and it's called now the CAN Patient Safety Culture Survey. So they've changed the name of it, and they've focused on slightly different things, and they've revised and removed some items. They've got rid of the shame and repercussion and talked about other things. So they've still got organizational leadership support, supervisory support, incident follow-up, unit learning culture, enabling open communication judgment-free, enabling open communication job repercussions. My guess is that this is not the final factor structure yet either, right? That there's going to be more changes because that communications, they've got lots of them, and I think there's going to be some, when I look at the items, I'm making a judgment that the data is not going to fit for very long. But the organizational leadership support and supervisory support has remained pretty constantly reliable. And if we look at surveys in other domains, like in industrial safety, again, we have the same mirrored effect of senior leadership support for safety, supervisory support for safety, as being basically the two dominant constructs. So I have some confidence that we're getting closer to something that we can measure in terms of employee perceptions around the relative priority for safety. So we're getting there. The psychometrics of these tools are improving. My sort of question about really what's missing here and where the title of the talk comes in, where's the patient in these patient safety culture tools? We're talking about leadership. We're talking about supervisors. We're talking about when something happens. We talk about learning, but it's all very inward focused. And from my mind, why don't we ask about patient engagement or anything about patients when we talk about patient safety culture? I mean, it seems like a really obvious thing now, 13 years later, right? And I was involved in some of these things, so I'm criticizing them, but I'm criticizing myself as much as anybody else. It didn't occur to me until about a year and a half ago that, wow, we just missed a big hole in everything we've been talking about for the past 10 years. That actually healthcare isn't the same as an offshore oil industry rig, right? That actually there is differences about the nature of the service and the nature of the industry that we hadn't really thought about. So I think a lot of it was because they were based on other domains. Aviation, they don't survey the passengers. They don't think about the passengers from a safety perspective because it's maybe not so relevant. We have maybe back 15 years ago when we started doing these questionnaires, there was less focus on patient engagement, right? So we did talk to people about patient safety. We went to conferences. Nobody was really talking much about patients. Now, it seems weird now to look back and say, well, when we went to a talk, we talked about a whole host of things, but the actual patient wasn't somebody who was really in the room to any great extent, right? They were sort of, part of the production process, but not necessarily had a stakeholder with a valid interest. And I think also the blame and reporting piece was the main interest from healthcare around patient safety culture to begin with. The cultural issue that people were interested in is why aren't people reporting? Why do we have this shame and blame approach within healthcare? And I think that was a big issue. So what was interesting, I hired a postdoc about a year and a half ago, hence my change of perspective on this, Andrea Bishop, who's now working at Dow. And she had done her thesis looking at that interaction between provider perspectives on patient safety and patient perspective on patient safety. And, really, it really highlighted for me that we'd missed that piece. Her thesis was quite important on that. But also she started asking providers about how they really view patient engagement. And it was surprisingly negative, right? That actually, while we say that if you have a concern, just ask me type questions, if you're concerned about, whether washing my hands, raise a concern, actually, in the interviews, the healthcare provider said, I would probably treat someone, less well after they had raised a concern, or I might hold that against them. And as a patient, if you're lying on the bed and you're wondering, did this person wash their hands or not, you've got a dilemma. Do I say something because I might acquire an infection, or do I say nothing because they might hold it against me later, right? And really, we've done very little work in understanding what is it that's driving providers' perceptions of patient engagement. And we have done very little, really, to support patients in navigating that area. So I really think that's one of the biggest issues within healthcare around the culture that we're trying to create, is where are we putting healthcare providers in terms of this concept of patient engagement. So we don't ask in any of the surveys about, for providers, how do you feel about engaging your patients in raising concerns? How do we respond to someone who's asking those questions? So what Andrea found when she assessed this, she assessed 4 dimensions. She asked about factual exchange of information, encouraging patients to challenge providers, efficacy, and workload. And she surveyed providers and she surveyed patients. And, providers were somewhat more positive, or at least less negative, would be the only way to frame this. On a 5-point scale, some of the means, and 5 being more positive, 1 being negative, a number of the means were in the 2s, right? So you're getting there. Majority of people disagree. This mean, I think, was 3.1 or 3.2. So, you know, there was slightly more people in favor than against it. So asking, patients are provided with written information about medications they've been given would be a statement, agree, disagree. Also, patients are encouraged to ask questions. I would be positive if someone asked me a question about the medication, right? So the idea is you could ask your providers, how do they perceive or how would they respond to someone who raises a concern? And this is not going to give you accurate information, it's going to be biased to an extent, but it's good to ask that question at least to give people a sense. You know, to what extent are they encouraged to do these things? Do I think it would be worthwhile? So if patients advocated for themselves, if they raised concerns, would this actually be helpful? And I think that question was quite telling. So they didn't think it was going to be helpful. So again, they don't necessarily think patients add any value. So if I've got a concern, my concern is not going to be useful. So why would I listen to someone who's raising a concern? And from my perspective, from a cultural perspective, I think, how can you know anything about your culture if you're not asking those questions to the frontline staff as part of that process if you're going to assess culture? And people indicate to an extent it would increase their workload. So if people start asking me questions, then that's going to take more time, those sorts of things. That was less of a concern. So from me, the arguments, so believe it or not, I've actually covered 2 of my sections. I'm not doing too bad. So I've given you what I think is an overview of what safety culture is about, and also why I think patient safety culture should be included as perceptions of patient engagement is a missing element from perception surveys that we may use within a healthcare context. So if you're going to do an assessment process, you need to create a team. You need to select an approach, what sort of questionnaire you're going to use. You're going to have to conduct some form of assessment, so whether it's going to be a questionnaire or focus groups or interviews. You need to interpret the results, so you need to try and understand them, which may be sort of descriptive statistics, etc. And then you're going to develop an action plan. So the purpose of doing a patient safety culture survey is to identify ways to improve. If you're not planning to improve, then don't bother to do the survey. Right? So many entities, and to a certain extent Accreditation Canada drives this a bit, they do surveys on a regular basis, but it goes nowhere. Right? They do the survey because we do the survey. Right? We've done the survey every year, we've done the survey every 2 years, it's time to do the survey again. But in doing it, there's no thought process as to why the hell I'm doing it. Right? You know, we do it because we do it, rather than actually we want to identify what are going to be our strategic priorities for improvement over the next year, how are we going to drive that improvement, and how are we going to make sense of it. So developing the action plan, you need to think about that at the end. And if you're working at a unit level, that's less challenging because it's going to be much more focused. So if you're wanting to assess the culture within a unit, which is the one where there's the most evidence that it works most effectively, is, well, we would select some sort of instrument, there's lots available. We would conduct the assessment, which might be done in a meeting with a group of people at one point in time. We would maybe interpret the results there and then, right? So the people who completed the survey are the people who provide you interpretation of the results. And then we would spend some time developing an action plan together. Because that's what works, is that the people who we're trying to influence design the intervention to make the change. So the other part and the reason for doing the assessment is really about improvement. When we talk about patient safety culture improvement, what are we trying to do? And for me, again, I think the thing that's been missing in this process is, are we really clear about, at a local level, what is the culture that we're trying to create? What is our vision for the type of culture that we're trying to create? I used to have a slide where I talk about pathological, bureaucratic, and generative cultures within organizations, which from Ron Westrom's work. And you know, I'd often get people to put their hands up and say which sort of culture they thought they were in. Was it pathological, bureaucratic, and generative? And you know, you get people in pathological, you get people in bureaucratic, you get nobody in generative. And then I'd say, well, which one would you like to be in? Where people are treated with respect, where people are valued, where their opinions are treated, are used. And everybody would say generative. So everybody wants to be in a generative culture. Well, why aren't we, right? Because ultimately the people sitting there are the people who are creating the culture. And I think what we should be very clear about is we should be clear about what is the vision for the culture that we're trying to create in this local unit or in this organization. What would that look like? What does good look like around here? And then, based on what would good look like, then that has responsibilities for different groups of people. So physicians, supervisors, managers, healthcare providers, all of us have different responsibilities in that context. So we should be clear about what our responsibilities are to create that culture. In doing that, we need to have some plans and actions that we say, if you've got a responsibility to lead and to support people around creating this desired culture, then what are the plans and actions that are going to support you in that process? How are we going to be able to ensure that people have that, the skills, knowledge, the systems in place to make that happen? We want to probably do some assessment to work out, are we actually going in the right direction? Are these plans and actions working? But the assessment, you realize, comes towards the end, not at the beginning of the process. We first need to decide about what is the culture that we want before we decide what we're going to assess. We then review and revise our plans based on the results from these outcomes, and it's a continuous process, right? There isn't a sort of end point where we have the culture that we want. We're continuously going through a loop to improve the culture that we're trying to create. But what's important, and I think what's important at a local and unit level, is we need to decide what is the culture that we want here. And that decision should be something that when you write that vision up, everybody should look at it and say, that's where I want to work. I want to be treated with respect. I want to be valued. I want to be enabled to do the best job I can. I want to learn from the mistakes I make and not be criticized. I want to be, whatever those values are that is relevant to that unit, that they write themselves to say, this is where we want to be. And accepting that we're not there now, but it is the journey that we're trying to take. And the rest flows from that vision. Rather than randomly creating things, we have one vision, and everything else that we do supports that vision to a greater or lesser extent. One of the things in terms of improvement strategies that I think has been missing, or one of the levers that we've not made enough use of in healthcare, is patients and families. So spending time with healthcare providers, you clearly realize that actually what they're passionate about is the patients that they care for. That's what gets them up in the morning. That's why they work so hard, is that they do it for the people who they work with. And in some ways, at times, that can be a challenge from a systems perspective. What's right for the patient in front of you in terms of what's best for them sometimes is not best for the entire system, right? So I might put my patient who's in front of me ahead of maybe another system priority in terms of my time. So people are very focused on treating the people who work with them. Yet, we make no use of those people to drive change. We talk about getting the CEOs and getting leaders to walk around and do management walkabouts and talk about patient safety, and that's a good thing, right? There's some evidence that it works. But I think the people who would really influence healthcare provider perspective is actually the patients who they are treating. And we have not made much use or any use of their voice in a process of change. And I think that's one of the big opportunities that healthcare providers have to be able to move things forward. Patient and families are able to provide feedback to healthcare providers in a way that will be helpful to move things forward. They can tell us things about cleanliness, staff communication, workloads, adverse events. They're able to be a source of information that's really valuable. They can provide feedback as to their experience in terms of how they were treated and how they felt they were being treated by their healthcare providers. And if we could provide that data back in a timely fashion to the actual providers themselves, then it would be a far more powerful tool than what we're currently using it. So family and patient perceptions is heavily understudied, very few studies done. And I think their experience really could provide a very insightful insight into the culture of a particular unit. in fact, it would be far more insightful in many ways than the provider perception surveys that we use. And I think it could be a real lever for change and improvement. So we decided to do this in Nova Scotia. So we've surveyed 500 Nova Scotians to try and see, well, what information would they be able to provide to us about their healthcare experience. We were sort of doing this because we knew the district health authorities were going to go through a merger process. So we did it in sort of March to May last year, before that sort of process really got started. And we have the participants' names, so we're going to track them through time to be able to see what impact does merger of a healthcare system from a number of different districts into one have on the patient experience. So we'll have some interesting data. Interestingly, we did this independently. We couldn't get too many of the DHAs to participate in this process. So we want to look at, well, what is about the end user? So we looked at care experiences, safety issues, discharge continuity of care, and medical errors, because this is the term that patients understood in terms of harm that might have occurred to them. I'm not going to spend any real time talking much about the data, but given that we'd measured their patient experience, we asked them about whether they'd experienced an error, and we found that things that predicted it was negative experience with providers. The ones that highlighted in red were the ones that were statistically significant. Conflict information given to the patient, not involved in care decisions, and hospitalized more than 3 times. So if you're a sort of frequent hospitalization, you're more likely to experience an error, which sort of made sense. But the other ones were really about your relationship with your provider, not being given the right information, and not being involved in decisions. So from us, and this is very early stages in terms of its cross-sectional survey design, but it is interesting to us that the things that seem to be related to your experience of error are things that we also know from a cultural perspective we're trying to achieve and improve. We're trying to ensure that patients get clear information about their treatment and that they're not given conflicting information. And having a negative experience with a provider also is not necessarily a good indication of the culture in that unit. So from our perspective, this I think is where I'm going in terms of patient safety culture, ironically, is that we're actually talking to the patients and trying to drive that as part of our improvement process. So the main safety issues that people were concerned about were wait times, provider busyness, coordination problems, comfort levels, cleanliness, and personal safety. I'm just going to finish with this as a sort of thought process for you to think about in terms of improvement. So I don't know if people are familiar with the CPSI videos of patient stories, right? There are, I think now, about 12 of them. And I think they're very powerful stories. And I really wonder in my head how they're actually being used within a healthcare context, right? So beyond them turning up at a conference or being played at some sort of training event, how are we actually using these stories? So we went online and for a conference paper, we analyzed the 11 videos describing by patients and families describing a serious adverse event. So they're edited, so they're not sort of completely authentic, but we have a sort of sense that it's a true representation of their story. In each video, a person describes the event, how the healthcare system failed them, and the impact and changes required. The storytellers are knowledgeable about patient safety, and they actively were involved in promoting improvement. So that's the sort of the general sort of gist of those sorts of stories. And we went and analyzed those, and we went and looked at each story as its sort of entity, and I tried to identify the common narratives that were present across those stories, and we interpret those to try to get some insight into the healthcare culture in general. So this is quite a high-level generic thing, but when we looked at the commonality among those stories, what was it that really struck us? The most common theme to me was one of unheard voices, that the people who were being harmed by the system were desperately trying to tell people what was wrong, but could not be heard. The healthcare providers did not listen, and in many cases, actively hostile to people who were saying that there was a problem, particularly if you were yourself a healthcare provider. There was one particular story from Newfoundland where a child died following an operation, and her mother was a nurse in that hospital. And ultimately, that person had to leave the hospital because she campaigned and said that the care that was provided was not up to standard, and that contributed to her child's death. They eventually had a review, an external review done, which confirmed that and showed that the child's death was preventable. Yet at every step of the process, the professionals were both hostile and unwilling to accept what this person was saying. And there are many cases where that is, in fact, the reality. Now, obviously, we're talking about a very small sample and of ones that have been picked out for a particular reason. But to me, and when I've spoken to people, it resonates with the challenges that healthcare faces. I think when people watch those videos, when healthcare providers watch those videos, they think it's sad, because all of the stories are pretty sad, particularly the death of a number of different individuals. But the learning from a cultural perspective is really that those videos hold a mirror up to healthcare and say, this is what you can be like sometimes. And that's the learning that the healthcare providers should be getting, is what is this like in our local unit, and how do we change? And I think those videos have the potential to be a driver for change within healthcare, because it creates a window to have that conversation about what we really are like, maybe at our worst moments, in fairness, but what we can really be like, and how we need to change to be less likely to be like that. And what would that look like? And what would that look like in our local department? So for me, I can imagine a training session whereby people look at one or two videos, they analyze them not for the sadness of the story or the technical failures that occurred in that context, but from a cultural perspective, saying, what is this saying about healthcare? And is that true of us? And I think for me, when we talk about change and cultural change, the way that it works and why we use the surveys is not because of the score, but because it can reflect back to people, like looking in a mirror, what are we really like? And maybe what are we really like at our worst moments? But it's at our worst moments that we probably need to work the most to change. And it's only by understanding that cultural context and understanding what we're really like, because when we're in it, we can't see it, but stepping out for a moment and have someone else put that mirror up to us and say, this is what our culture is like. Is that good? And how would we like it to be different? And it's that conversation piece that is the real power for cultural change. So what I want to leave you with is that sort of thought process when you go back to your healthcare organizations is, what would it look like to be able to put a mirror up to your culture and feed that back to your peers? And by doing that, that's what will drive the cultural change within your organization. It's not going to be survey results particularly. It's not necessarily going to be about saying we need to work harder or be better. It's going to be about how can we hold a mirror up to ourselves to look at our culture, reflect on that, and decide as a group how we want to be different. Not because someone said we should, but because we're not happy with the image that we're seeing in the mirror. So thanks for your attention.
Board, of course, knew I was going to ask a question about this. Really appreciate your comments about the need for patient engagement. One of the elements that might be helpful in terms of how you actually do this, which you didn't speak to, and that is the notion of power and the power differential. And there's a little vignette that I think illustrates it. A few years ago, we were doing some work at the Peter Lougheed Hospital, and the fellow who was the chief physician there, lovely, lovely man, hurt his arm and was a patient. Now, at this time, he was the most senior physician in the hospital. He was the head of the infection control committee. And as he describes it, as he sat there in the Johnny shirt with his bottom hanging out, a little nurse came in to change his dressing. And she dropped her gloves on the floor. And he watched as she picked the gloves up and put the gloves on. And when he was telling the story to us, he said, you know, I couldn't say anything. I found myself unable to say anything. Now, this is, at the time, one of the most powerful people in the system. And I think unless we address the differential, unless we find ways to invite providers to say, patients can't say anything to you unless you invite them to say things. And when they do say things, because of that differential, if you're not able to hear them, we can't move this forward. So I would like you to speak to the notion of power and how we address power, because I think until we do that, it's going to be really hard to get the kind of patient engagement that you have inspired us to dream about.
Yeah, so thanks. Yeah, so power is one of the barriers for the patient to be able to speak up. And from my perspective, by surveying the patients, so most healthcare organizations do patient satisfaction surveys on a routine basis, right? It asks questions that are maybe important, like parking and food and a whole bunch of things, but it doesn't ask about how comfortable do you feel about raising questions, right? And how comfortable were you willing to do this? Were you aware of harm that occurred to you? Were you aware of the cleanliness? A whole bunch of things. Did your providers wash their hands, right? These are things that we could include in those surveys. And to go back to the power issue is that people, right, me, you, everybody, we're just normal people, right? And some people may be given a status in some context of having some power influence, but most of us live in the world where we don't see those power differentials in many ways. So to provide that feedback to staff to say, the people who you treat do not feel comfortable raising questions, starts that conversation about what do you need to do as the provider to change to create that environment for the person to ask questions. So I think that's how you deal with that power differential is you make them aware, not calling it necessarily power, but the people who you treat are afraid to ask you questions, right? And then that should, at least if you're giving you that feedback, raise the question, why? And when they ask why, then you can say, well, there's a power differential is one of the reasons, but also you don't ask them to ask you questions, and actually, maybe they're afraid that you're going to treat them badly if you do. And actually, maybe you are, right? So I think the conversation needs to be quite broad, but I think what I'm advocating to deal with that power is to provide that feedback to the providers to say, actually, most of the people who you treat are afraid to ask you questions. And that, I'm hoping, and I don't know, I have any evidence that this would work, but that seems like a good starting point for the conversation of what do we need to do differently to facilitate that, right? I think that's part of it. You're dead right. Power is one of the reasons why we don't ask questions. The other reason, though, is that actually sometimes we make it clear we don't want people to ask questions, right? You know, so you ask one question and you get a put down, and you know the second time not to ask the question. I use that often. I don't ask questions. Sorry, joking. Oh, you need a mic.
Thank you so much. Is there, as part of holding up the mirror, has there ever been studies done where you've said, here's providers what you said about how well you speak to patients, how open you are to those questions. Here's what the patients actually said, to then look at the gap as another part. Is there any utility in that in helping move that change forward?
So I think there probably is in terms of how you might approach that sort of problem. To the best of my knowledge, there's very, very little work done at all. So Andrea Bishop's thesis is one of the first studies that has looked both at the patients from a particular unit and their results and the providers. And to be honest, the organization wasn't desperately keen to provide the results back to the providers, right? And as we've gone forward with that work, I must admit I've made a deliberate choice not to engage any DHAs or healthcare providers in the process, and we're going out and using marketing companies to go and collect patient perspectives, just because when we started the conversation to try and do it, it became impossible to get a process that was going to be meaningful, that we could collect the data. So there's been, at least at an administrative level, and maybe it's just me, I'm not sure, a fair amount of hostility to the concept of asking patients about their experience. You know, the standard one that was the deal breaker for me was, oh, well, we don't want you to ask patients about their experience of maybe having a medical error, because that may make them afraid of coming to be treated, right? So we couldn't ask them that. So we said, well, we can't participate then. So we went and paid for people to go phone people up and find patients. So I think that's a big challenge. I think that's a cultural challenge, that we don't trust patients enough to have the maturity to be able to be aware that they could get harmed when they go to hospital. We think we treat them as children who don't have that, and that's a bigger concern for me, but that's a whole other story.